Healthcare is changing. Ophthalmologists need to see more patients in a shorter period of time. Qualified staff is getting more expensive, is getting scarce. How do you manage through this? How do you manage through this in your practice? And how do you see ophthalmology overall having to change?
Great point. I mean, I think you're absolutely right. The influx of patients coming our way now in the next 5-10 years is incredible. And I think we're seeing less amount of ophthalmologists coming out of residency and fellowships. We're actually seeing harder time getting staff. So you need to increase efficiency. I think the throughput of seeing patients has got to be more efficient. I think we're using more technology to help do our diagnostics in an efficient way to give us all the information we need at one time to then make that decision. I think utilizing, of course, optometric colleagues as well. And then having more access to technology as early as possible. For instance, speaking specifically in glaucoma, I think for me, treating earlier in the disease state, decreasing the drop burden for our patients, for me as a glaucoma specialist, has been a huge paradigm shift for me, because the amount of time we found that we saved just by getting rid of one topical medication, we saw a savings of time per patient, per visit, per technician, about 5 minutes. All the callbacks, the verifications at the follow-up visits. Are you taking your meds? Do you need refills? All of that takes time. And then the uncertainty when you're making a decision, is it a compliance issue why they're getting worse in glaucoma? Is it because they need lower pressure? So to me, utilizing new technologies, various technologies early in the disease state to decrease the drop burden and help that flow and follow-up is huge in glaucoma.
How has the treatment of glaucoma shifted over the last years, also over the last recent years?
Yeah, I think we are appreciating compliance is a difficult issue to manage, and we realize that almost every one of our patients is non-compliant. No matter what we do, we try our best to educate. It's really hard, and we just mentioned earlier how much time our staff spends on dealing with compliance-related drop-related issues. But now we have data. We have data from multiple MIGS trials, phase 3 trials, large trials that show us, despite the same average IOP reduction, right? If you have someone off of medications versus someone who's on medication, despite the same average pressure reduction, the patients who are off of meds tend to do better because more stability of IOP, less potential for, kind of complications of the drops and the BAK, et cetera. So I think the biggest change, paradigm shifting, is addressing and appreciating that we need to get the people off medications. Our definition of controlled glaucoma is no longer is the pressure good at that one visit or the fields are stable, is what's the likelihood of that patient staying on that medication burden long term. If that patient has compliance-related issues, whatever it might be, cost, side effects, forgetfulness, that patient is not controlled no matter how good their pressure is on that visit. And that's kind of the same, that's a change that I've seen over the last few years.
Where do you see the place for inflow control there? And where do you see the hurdles to adopting it?
Yeah, that's a great point too. Think about it from a pharmaceutical perspective, right? We use multiple mechanisms of action with drops all the time. We have carbonic anhydrase emitters, we have, we have of course alpha agonists, and we have PGAs that help outflow as well. So we have inflow and outflow in that drop world. And so from a surgical world, we have a lot of outflow facilitators, but we don't have a lot that we can do for inflow except for using ECP type of procedure as well. So I think it's a potential benefit for more surgeons. They don't really, I think, use it enough, in my opinion, as well. And using it in combination, like we do with topical medications, with outflow procedures, can get a significant reduction of IOP and reduce the drop burden for these patients, even the more mild to moderate kind of patient as well. I think the difficulty, to your point about the adoption, has been access. I think some surgeons felt like the previous iterations of ECP were hard to get, hard to use. The staff had a hard time setting it up. We talk about the actual probes that were non-disposable, so the quality of the image got worse. So I think there's a lot of misperception of ECP, and I think the efficiency and flow and the access was a big issue, and the comfort level of utilizing the probe was not as easy for some surgeons.
What are your thoughts on IQ Flow, how this is addressing the challenges that have been there with ECP so far?
Pretty impressive. No, I mean, I was like, wow. Well, first of all, I mean, the ergonomics, right? You don't have a large console that you have to, plug into. Everything's at the tip of your hand, which is great as well. And so having this chip with the high quality imaging, and the quality of the imaging, it's all about the view. If you don't have a good view, you don't know what you're treating. And I think with ECP, it's as important, if not more important, to treat and ablate the right tissue, the ciliary processes versus iris tissue or ciliary body tissue, right? So you really want to make sure you know what you're seeing. I think that the IQ quality of that chip is pretty impressive. Number two, I think having software that allows it to maintain its orientation is probably one of the biggest, I think, advances you guys have done, because so many surgeons really struggle with this. You know, when you turn your hand, you're trying to get around the angle and trying to get around the circumferential part of the eye. It's easy to turn with your hand. Then all of a sudden you're not quite straight, and you have to have a technician press a button to reorient yourself, and then you get frustrated. You don't treat the proper areas, you don't treat enough, and the efficacy is not there. So I think having the ergonomics, having a disposable probe with high quality imaging, and then having the software to allow yourself to really orient it consistently so that surgeon doesn't have to think about that, just can focus on that necessary processes and just press the button, you know, either on the fingertip or of course on a foot pedal as well. So I think the ergonomics, the access, the quality, all those things are going to be a huge benefit for patient or doctors rather.
Where do you see other applications of the endoscopic function? Especially you already know that the IQ Flow will also be connected to IQ Search View, the scope. So you're going to have a picture-in-picture. Where else do you see using endoscopic views in your practice?
Well, first of all, I think that's another good point that I didn't bring up as well. Having it attached to your scope, right? The scope becomes the workhorse. It becomes more than just a kind of a visualization only. It can bring all your technologies together, help guide you more than we have with other scopes. So what is a frustration, I'm a huge fan of 3D heads up in general, but the reason why I love it so much is I had neck surgery. But the problem is if you're having to turn your head this way or this way to look at a separate screen while you're doing surgery, it causes problems. It's also hard to focus when you're trying to focus over there and your hands over here. So I think if you have a scope that has a kind of a picture-in-picture where you don't have to look separately, you can look at your screen, I think that's going to help surgeons feel more comfortable as well. Secondly, when you have easier access, easier ergonomics to the device, right? You don't have to set up a whole machine, it's just a plug in and go in. You can use it for so many other things. There's a lot of other conditions that we are managing in the anterior chamber, whether it's other MIGS procedures to look at. I could use this instead of turning the head and scope, hold this there and place my stents or my canal dilating procedures or drug delivery, or going behind the iris when we're doing our ACP, looking at, let's say you have a patient with a, UGG syndrome where you have, let's say the haptic's not in the right position. You have to do a lens exchange. There's so many other conditions in the eye that we need to utilize, or we could utilize this as a visualization kind of product versus just a treatment for ECP.
Now, we have a lot of new technologies, and we talked about the environment that ophthalmology is living in right now, right? Decreasing reimbursements, more patients, more efficiency. Now, very bluntly, what role does it play when you are evaluating new technologies, if this is going to increase revenue for your practice or decrease costs? Is it like in the top?
Oh yeah. So I mean, I think when I have any new technology that comes to our practice, what I'm looking at is, does it fill an unmet need? Is there something medically for a patient that I have not been able to do, or can I do something much better to help a patient? That's the primary goal for me, at least, right? And hopefully that's still our goal as physicians. But number two, is it helping our flow? It may not have to help financially upfront, but is it helping more efficiency and flow, which indirectly helps financially? And then thirdly, does it have a better reimbursement, right? Now, if it has all three, if it meets an unmet need, if it's giving me better flow and it gives me financial benefits, then it's a no-brainer. And I think those are three things that I look at.
When you heard about IQity and the mission of IQity is to help ophthalmologists deliver better outcomes while saving time and reducing cost, what were your first thoughts?
Finally. I mean, look, I think I could speak for most surgeons here today and those around. What's what we want? We need that. We don't have the time. We don't have space, right? And we are getting decreased in our reimbursements. Our overheads are going up. We're the only field that actually has decreased reimbursements and increased costs as well. So if you can have something that allow us to consolidate, have more access, help with reimbursement, help allow us to be more efficient, I think that's what we need. And so it's about time. So thank you for bringing it.